Hi, Dr. Peter Osborne here with another episode of Functional Health Summit. And today we have a great guest speaker, Doctor of Medicine, Dr. Frank Tortorice. He's an internal med guy out in his practices in San Francisco, and he oftentimes is referred to as Dr. T, the Diabesity doc. And he's got a complete different approach to treatment of obesity and diabetes from a functional medicine perspective. So, Dr. T, thanks so much for being here and sharing your expertise with us today.
Thank you very much, Dr. Osborne. Pleased to be here.
So let's jump into what makes things different. You treat a lot of obesity and diabetes and cardiovascular kind of oriented based problems. Let's talk about how your approach is a little bit different, and kind of how you would walk through a new patient, how you would walk through that might be different from the allopathic model.
Well, yeah, thanks for asking, Dr. Osborne. Yes, it is. I've been practicing internal medicine for, nearly 20 years now, and it recently became more apparent that patients sometimes do not respond to the allopathic method. I have my MD degree and my certification, but I also was fortunate enough to study with the Institute for Functional Medicine, and there they have a comprehensive training to help patients such as the ones we're talking about, the ones with diabetes or what's called prediabetes, and lipid abnormalities and weight problems and heart disease. They have a different approach that really looks at the causes as opposed to just a Band-Aid to mask or cover the symptoms. Most of these chronic illnesses, as we're finding out, don't respond to the bullet approach where you simply give one pill for the rest of their life and then they're better. What's happening is they're getting more complications and they're getting a lot of comorbidities because of this. So through the training in the functional medicine method, we look at causality factors and try to get to the underlying causes and try to treat those to remove the symptoms. So most of their disease may be, like an iceberg underneath, the shoreline there where it's underneath. So by approaching root causes and getting at the antecedents and mediators of their disease, we sometimes can improve their diabetes to such a degree. So if they're on oral medications or injections or other pharmaceutical agents, it may be appropriate at times to either decrease or actually get them off their medications. And a lot of patients, frankly, want to go that approach. They're tired of being on expensive medications, which in some instances can actually either cause or exacerbate diabetes or lead to heart disease, and they have a lot of side effects. Patients are very savvy these days, and they come in, they've done their research, and they want to partner with you. The thing about functional medicine is that they become a partner. It's not, you're not talking down to a patient, but you're working together, you're collaborating, and it takes more time. It's more time intensive, but I think ultimately it's more rewarding for the patient because you can remove the disease. A lot of times if they have type 2 diabetes and they're carrying a lot of extra weight, they have insulin resistance. So by getting their weight to a more manageable level, they can either get off of medications or certainly reduce a lot of the medications they're on. So I think that's what's exciting for us, and we enjoy doing it.
But it sounds a lot like what we've heard so many times with some of the other speakers during the summit, in that you look for a root cause, you look for where the origin of the problem might be, or what would empower the patient to make change in their life to be able to enjoy good health without the need for just the chronic ingestion of medication. You mentioned comorbidities, and I want to kind of back up there because you said that a lot of times what happens is the medicines, their intentions are the best in the world, but the outcome is that it creates side effects that can lead to or contribute to other problems in these patients. And then that in and of itself has to become managed with more medication or more forms of treatment. What are some of you? So you treat primarily, diabetes, obesity, and cardiovascular type scenarios. What are some of these comorbidities? What are some of these things that you commonly see that you're able to change or you're able to get rid of just by taking a functional medicine approach?
Well, Dr. Osborne, I think there's a whole litany, but just to give a few that probably a lot of the listeners may have heard of, such as statins. Statins, I think, initially were prescribed with good intentions and to a class of patients with cardiac disease, and in those initial studies there were good outcomes. But recently it's been broadened, the use of statins even nowadays to children. So I'm not sure those were the original intentions. So certain statins can actually cause more diabetes, and they certainly can cause muscle pains. They can cause dementia. They can cause memory loss, and certainly if it's not managed appropriately, they can cause a whole list of these side effects. And the problem is that what happens is you have a patient of a certain age, and he goes to the doctor and says, "Oh yeah, you put me on that statin a month ago, and boy, I just can't remember anything." And the doctor will say, "Well, listen, you're getting up there in age. It's normal to have a little bit of memory. Don't worry about it." So what happens is it never gets tracked by the the centers that go look for side effects of statins, or they say, I got these muscle pains, and I can't really walk like I used to, and the doctor will say, "Well, listen, you're up there in age. To have a little bit of arthritis is certainly understandable. Just take over the counter, Tylenol or Advil, and you'll be okay." And again, these can be actually limited. They can be shown to be caused by the statins. I have a number of patients that come to me and they say, "Doctor, I was getting pain with that statin that the doctor gave me, and I have to tell you, I stopped taking it 3 weeks ago, and you know what? My pain and my memory and everything is a lot better now. Do you think it has something to do with the statin?" So that's for statins, and then some of the other diabetic medications have problems with some of the early studies. So cardiac disease or congestive heart failure, which some of the classes of medications, some were actually taken off the market, things such as Avandia and Actose and Resulin. There are some post-marketing studies showing that there was increased risk of cardiac death and congestive heart failure with some of these medications, and now they must be limited to how you prescribe those only in very severe or recalcitrant patients. So again, the litany goes on. There's cancer and some of the other medications. So again, patients are coming up to us and asking us, "Listen, we don't necessarily want to be on prescription medications, only if necessary." So because I can't prescribe medications, sometimes they want to just get my opinion on which way to go with that. So we talk and we discuss. We make it a team approach. And with functional medicine, it's a dialogue. It's not a monologue where I tell them what to do. We sit down, we talk. We're able to spend enough time with the patient to try to more fully answer and give them the courage to move forward, and we can see them in a more comprehensive visit, so we can really get an idea of what's going on with them, and then they feel more comfortable with that. And many times we've gotten patients off their medications.
I love what you said. It's a dialogue. It's not a monologue, and I hear this so many times from my own personal patients, and that they may be coming from a different doctor's office where their doctor, they like what you also said about statins. "Hey, I was complaining of muscle pain. The doctor says I'm just getting older." A day after being off statins, the muscle pain dramatically reduced, and the doctor still doesn't want to comment on it. But what you're saying is, really, from a functional medicine perspective, the relationship between the patient and the doctor is kind of an equal relationship. Everybody is talking, communicating, and trying to get to the same goal, which is a betterment and improvement of the overall health of the individual. And I just love the way you put it, a dialogue that's not a monologue. Yeah, I'm going to use that, I think. So excellent way to put it. So you work on trying to get patients to a point where they're literally they're able to kind of manage themselves, provided they're educated well enough to be able to do so. Is that a pretty good assumption?
Yes, it is, Dr. Osborne. We're lucky enough to have a full-time functional nutritionist, and I learned early on that a 5 or 10 minute visit with a complicated patient is just not going to cut it. And we're able to have them meet with our nutritionist for 30, 60, or 90 minutes, and when we go through everything with them, we have a slideshow, we have multiple handouts, we go through a lot of the roots of their diet, and make no mistake about it, type 2 diabetes can be reversed, or dare we say cured. You can be a diabetic but not have either complications or the need for any prescription medications. It's a lifestyle-induced condition in a good majority of cases at this point. So we try to see if they're open to that, and if they're seeking that type of treatment, then we work with them and we participate. And having a staff that is functionally trained makes it happen that they get the same message from everybody, all the members of the healthcare team, and I think this is really important.
What do you see in your clinic as, the biggest impact changers on diabetes and obesity? Like, if you could only give out, 3 pieces of advice to a patient, what do you see those 3 pieces of advice would have the greatest impact on these types of patients?
Well, number one would be the diet. I think a lot of the information that they get from, either television or media outlets is on a diet which I think does not serve the majority of our patients. A low-fat, high-carbohydrate diet is the last thing that I believe, in my opinion, diabetics need. So we try to work with them to limit their carbohydrate intake. In the same vein, I think there's a lot of confusion about gluten and wheat, and gluten being in other products beside wheat. We've seen major changes when patients just remove gluten and gluten products from their diet, and we make sure they don't substitute with high sugary, gluten-free alternatives. So our nutritionists and myself, we really encourage the patient to move forward with this. We have cookbooks, we have handouts, we have videos that they can look at, and it's scary for a lot of our patients because they don't know what to do, and they certainly don't know what is gluten, and they've kind of heard about it, and isn't this just a fad? But we've seen people lose tremendous amounts of fat weight and normalize their blood sugars, feel better, get rid of headaches, get rid of joint pains, get rid of rashes, just from the reduction in the gluten and the reduction in the processed carbohydrates, and then the industrial oils as well. And another thing is the industrial oils they have to remove. By law, when they go for fast foods, the fast food companies or the restaurants are allowed to change the oil only once every 7 days, and that's just such a pro-inflammatory food, if you want to call it a food, that we try to get them on a very anti-inflammatory diet to shut down the furnace in their arteries and in their veins. We use the picture of a furnace or a stove on full high, and everything's burning rapidly because of the inflammatory changes. So that's what we do. And the other thing we do, I think that helps, is patients a lot of times will feel more compelled if they see numbers. If they see their numbers are out of whack. We do a number of tests to look for inflammatory markers such as hsCRP and some other markers that we use, high sensitivity C-reactive protein, and we track certain blood markers for inflammatory changes, for their diabetic markers, for their types of cholesterol. We do advanced cutting-edge testing, not only to check the cholesterol number, but the cholesterol types and the subparticles to see what is actually going on. As you know, it depends on the ratio of triglycerides to HDL. If they have the large fluffy type of cholesterol, they have the small, dense type of cholesterol. It all makes a big difference, and the same numbers can mean different things depending on the particle size and the quality. So we try to really encourage the patient to be an active partner and to see that they have the power to manage their disease, and we're just here to help coach them and help provide some expertise to make sure that we're moving things along to get them to enjoy the best health they can.
Again, so refreshing to hear that type of mantra, coaching versus dictating. Patients being able to play a role in an active role and seeing that they have to play an active role. I think that's probably one of the biggest points. It gets left in the clouds. It doesn't really get talked about. And I think too, Frank, Dr. T, sometimes we see people so badly attack the medical community. The traditional medical model of treating, the allopathic model, and I think it gets attacked almost to a point that it isn't really even fair that it's being attacked in such a way, because I don't think that there was ever an evil intention in medicine to basically to corrupt people and to make them have to receive treatment. I think it was all done with well and good intentions, but I think that ultimately what we see is we see people kind of downplaying, or I don't even know the right word to use here, downplaying or talking negative about the allopathic medical field when I don't think they're necessarily bad or evil. I think what you're talking about, which is looking at all these parameters and trying to merge the best that medicine can have to offer with functional medicine, but most importantly, empowering the patient to take role and to take action within the treatment. Because I think a lot of the mentality, as you've probably seen, I know I see it a lot, is the patient comes in asking for the pill. They come in wanting the new drug that's being advertised on TV. They come in not really wanting to play an active role, but just wanting the doctor to be able to magically wave their hand and make something happen for them that improves their health. And I think the fact that you're out there doing heavy counseling, heavy communication, heavy talking and educating with your patients is refreshing, and I hope that we see that trend continue to change in all of medicine, because I think outside of emergency medicine, when it comes to chronic disease, there's really no other way that we can be successful at battling all the obesity and diabetes and everything else that we face.
Yes, you're right, Dr. Osborne. I think maybe our parents or our grandparents, there was an old-fashioned way where the doctor would, slap them on the knee and say, "Listen, we're going to do it this way," and that was accepted back then. But nowadays, in our generation, patients want to be participants. They don't want to be talked to. They want a dialogue. They want to go back and forth with you. In many cases, some of these patients really know their stuff, and they're almost virtual experts, but they lack the clinical expertise that we have, but yet they have a lot to offer and bring to the table. I think it's important that we show them that we do things a different way. I mean, I had a patient come today the first time. He lost his insurance, and his doctor says, "Well, we don't take this new insurance that you have." And he came to me, and just to give you a brief synopsis, is a young gentleman, mid 40s, but he says, I don't feel fat, but I can't lose this extra weight. And my other doctor told me I was okay. So we looked at his limited labs. He had a BMI of 32, a body mass index of 32, which is in the obesity range. And his fasting blood sugar was 110. And I said, you know what? With that kind of fasting insulin, you're not going to lose weight. You have your insulin so high, you can do what you want, but we have to make some changes here. And I ordered a number of tests that his other doctor didn't get, and told him that we do things a little bit differently here, but that once we got the lab tests, that we thought we could probably help him lose excess unhealthy weight. So things are changing. I mean, back when they developed penicillin, you could have a single microbe that would respond to penicillin, and you'd have a cure. But functional medicine and chronic disease, as you know, is multifactorial. It's based on lifestyle. It's based on exercise. Does the doctor ask about proper exercise? What about your sleep? How many hours do you sleep each night? It's about exposure to electromagnetic radiation. Do you have the lights on at night? Do you have it's a much more detailed approach if you really want to make significant changes in the chronic condition of our patients, in my estimation. So you can't do that in a 5 or 10 minute visit. You just cannot. And patients appreciate that you talk to them and that you dialogue with them. They really do. I mean, I think that there's a lot of trends out there where patients are taking in foods which they thought were healthy and really have turned out scientifically not to be healthy. So if they trust you and you show them good data, I mean, functional medicine is based on data. It's not based on, I have this feeling or I sense. It's based on numbers. It's based on functional testing. Just like an EKG is a static measure and a stress echocardiogram for the heart is a functional test. Well, we do functional testing for blood sugar and for other types of conditions as well. And with those functional testing, we're able to make more meaningful changes in the patient's treatment plan.
And I'm going to assume then that the follow-up on these types of tests, the parameters are greatly improved, and you really are able to really show that to the patient and encourage them to continue on the course, as opposed to once they hit I see this a lot too. Patient will hit a cholesterol goal, doctor's trying to reach, and it's all, the goal is all reached as a result of using a medicine and not as a result of the patient taking action. But when these patients take action and they reach these goals because of the action they took, not necessarily because of a medication, they feel more empowered, like they can continue to do this and continue to be successful at it. And I guess the big word is just empowerment.
Yes, it's true, because the thing is, traditionally we would do, the ancient science of cholesterol is checking, just like total cholesterol and triglycerides and LDL and HDL and so on and so forth. But, we've seen patients that have good numbers, but they have heart disease. As you know, patients can go to the emergency room and have heart attacks even with normal numbers in their cholesterol. And I've lost a few patients who died because, it was not picked up, and their cholesterol numbers were normal, but their fractionation, which wasn't done back then, would have been abnormal. Now we check, like I said, the advanced fractionation test, and we show it to the patient, and we're able to, once they see that you really care about them, and once they see that they feel that you know what you're talking about, and then they see when they come back that their tests are measurably better in a significant, medically important way, then yes, there's nothing more enjoyable for either practitioner or the patient. They're enjoying better sleep. They lost 10 or 15 pounds, and now they're able to go out with their kids more. They're more present in their life. Their brain function is improved. Some doctors, such as Dr. David Perlmutter, are calling Alzheimer's disease, type 3 diabetes. Make no mistake about it. You can have what used to be called pre-diabetes, but you're pre-nothing, because you have the same risk, or just about, of cardiac and mental deficiencies and memory loss and early Alzheimer's as the patients with diagnosed diabetes. So it's important that we do early detection as well, and we try to do that in our clinic.
So what are some of the early ways of detection? So if somebody listening to this conversation is wanting to go back to their doctor and have some of these things done, what are some things they could ask for?
Well, the first thing I would do is, a lot of times we'll do what's called a comprehensive metabolic panel. And a lot of times the fasting blood sugar may be in the 90s or even the early hundreds. But I think if you do that in the absence of either a C-peptide, a fasting C-peptide, or fasting insulin, because I look at it as a home loan. So one person can get a loan that's maybe 3% interest, and another one can get a loan that's 22% interest. There's a big difference. And what's going to cost you? The same thing. If your pancreas is secreting insulin, in high activity, that's not really healthy. The first sign to go is not your fasting blood sugar. It's an elevated insulin, and the insulin is elevated because there's insulin resistance. So the body senses that the blood sugar is still high, so it says, well, we got to secrete some more insulin. So come on, let's get everybody out there. And when you look at their insulin, it's extremely high. And then we show it to the patient, say, yes, your fasting glucose is either a little bit high or it's markedly high, and you're on the road to diabetes because your pancreas is going to finally get exhausted. So that's one thing I would check. The other thing I would check is make sure that the doctor, if it's possible, can do one of the advanced cholesterol profiles, such as a VAP, or an NMR cholesterol profile, which looks at particle size and looks at insulin resistance. And I think that tells you a lot more than the old-fashioned, basic cholesterol, where they say your total cholesterol, your triglycerides, your LDL, your HDL. That really doesn't tell you too much. Like I said before, I have a number of patients that had perfect numbers but had, type B pattern cholesterol, which is very pro-inflammatory and sticky, and the one that causes a lot of the plaque in the heart that needs to be removed. Another test for sure should be an HSCRP, high sensitivity CRP. If this number is elevated, it's a marker of a pro-inflammatory state, and that is another marker showing that the patient has an inflammatory condition in the cardiovascular system. So those are some that they can do. I think that's a good start.
So we're talking about fasting insulin, blood glucose, and high sensitivity C-reactive protein, all as being very standard markers that most doctors should be aware of and would be able to order, whether they were a functional medicine doctor or not a functional medicine doctor.
Yes, they are. It's just that they need to interpret that. I mean, whether a person has a fasting blood sugar of 80 or 100 is irrelevant until we know what the C-peptide from the insulin or insulin level is. Until we know that, we don't know, again, what the cost is to the patient to keep that blood sugar under reasonable control if he's not a diabetic yet. Once I see elevated insulin, then I treat the patient as if they're right on the border of diabetes, and I say, listen, we have to make changes now. We can't wait another 5 years till you actually become a diabetic, because as we found out from a lot of studies, the patients have risk of early dementia, Alzheimer's disease, cardiovascular disease, kidney disease, diseases of the eye, and all sorts of complications, even though they're not technically a diabetic. I mean, we don't wait till they become anywhere close to, the 6.5 in some of the standard hemoglobin A1C, or the marker of the 3-month glycosylated hemoglobin particle. So we get that right away, and we try to treat before then. I think that's imperative if you're doing a functional medicine, because otherwise you're risking that they become ill later on down the line when you could have been prevented or reversed.
Well, it sounds to me kind of like what you're saying is that you treat them as if they're diabetic when their markers start to show up. And let's back up, because you said it before, early detection. So I would assume what you're really referring to here is that early detection of what doctors would tend to call prediabetes in the public eye, in mainstream, which you're saying really isn't prediabetes at all. It really is existing disease. It needs to be aggressively approached before it turns into something more permanent. Yes,
that's very important. In fact, I was listening to a talk by David Perlmutter, and he mentioned it as well, citing a number of recent peer-reviewed journal articles from top-notch journals. They have almost the same risk as if they were already diabetic. So by waiting till they have that magic hemoglobin A1C of 6.5 or doing the oral glucose tolerance test, you're missing the opportunity to reverse it when there's maybe not any organ damage. And again, these patients are at risk for early dementia, even in the so-called or previously called pre-diabetic phase. They really are at risk for a number of complications, even if they never get to 6.5. Even having an A1C of 5.8 or 5.9 really markedly increases their likelihood of early dementia or possibly cardiac disease or renal disease. So we want to see their hemoglobin A1C at the very least around 5.4, and some doctors would say 5.0. But if I can get it to 5.5, 5.4, then I know I've done what I could, at least from the start, to reduce their possibility of comorbidities later on in life.
And so here you have this patient, let's say they have, non-diabetic at least according to the AMA criteria, but they have non-diabetic labs, but they're what we would call pre-diabetic or metabolic syndrome like. What would be, I know you would institute diet and lifestyle changes. Would there be any medications at this point in these patients? Would you recommend any medicines, or would you primarily go with lifestyle change?
At this point, if they're pre-diabetic, I think we can, unless there's something very strong in their history or family history, we can probably get away with a trial of lifestyle changes, exercise, sleep, and stress reduction. Having a full-time nutritionist who's functionally trained, they will go over with them and spend an hour and then follow up a few weeks later with a second visit, and we'll go through and just really emphasize and make sure that they really understand that, at this stage of the game, there's a lot they can do to reverse this. They don't have to become a diabetic. And in fact, we've seen a number of patients reverse it where it was past history. They just no longer were at that risk because they had reduced their risk factors, and we do everything through accurate monitoring and remonitoring. So, the numbers showed it, and everything from their waistline to their cholesterol to their hemoglobin A1C to their blood pressure to their total cholesterol and the cholesterol fractionations have come into normal range. They've reversed it just on making those lifestyle and changes that we mentioned.
So basically, completely reversible condition if we have a good compliant patient who's following through with recommendations appropriately.
No question about that. Even patients who are diabetic, who have hemoglobin A1Cs that remain above 6.5 but below 7, we've seen patients go 20, 30 years and have no eye complications, no kidney complications, no cardiovascular complications. So, it's not a death sentence to have diabetes mellitus. It needs to be managed, but they need to find a healthcare practitioner who is up on the latest in diabetes care, and they don't have to suffer any of the consequences. Diabetes, it may be impossible to get that A1C under 6.5 depending on a number of circumstances. But that being said, is what patients really fear is having a stroke or having a heart attack or being on dialysis or going blind or having a limb cut off, and they don't have to have any of those. In the great majority of cases, if they can be adequately managed and the inflammatory changes can be monitored properly and aggressively treated, they don't have to have any of the complications, which are the big fear of the diabetics, not having just a diagnosis, it's the complications and the comorbidities which strike fear in our patients.
So what, all that being said, if you could only do, and I know I asked you this earlier, and I'm gonna kind of ask it again, but in a different way. If you could make just one change, if you could only tell this pre-diabetic patient you can only do this one thing for them to be able to get the greatest benefit, what would that one thing be?
It would be reducing the carbohydrates. There's been a number of studies that show that taking somebody from a high carbohydrate diet to a low carbohydrate, higher fat, higher healthy fat diet, in some cases they've been able to get off insulin or get off their oral medications because certain foods incite an insulin response where other foods do not. So, my bane is also the industrial bad oils, but if I could only do one, probably carbohydrates number one, and number two would be the industrial oils that we see like canola oil and cornflower oil, or not corn oil, and some of these soy oil, soybean oil, some of these cooking oils that really in a lot of cases are really pro-inflammatory and don't have the right fractionations of omega-3s and omega-6s and things like that.
So really simply put, then, just you would say that carbohydrate, normalizing carbohydrate intake, and I say normalizing because we've been told for the last 20, 30 years that high carbs and low fat and low protein was normal, but when I say normalize, I really refer to bringing that ratio under control where they're not just getting so many carbohydrates that it's putting the pressure on their pancreas, putting the pressure on their liver to monitor and to control the level of blood sugar before it becomes a major disease.
Yes, it's really important there because, I mean, for many years, they would tell a patient just have whole grains, have some oatmeal in the morning, and pretty much it just the pancreas is just working on overdrive, and we go through with them and explain why that is no longer, at least in our view, the right way to go for the majority of these patients, that they're eating not very high processed food to some degree, or if it's not sugar, it's refined carbohydrates, which in the body recognizes as sugar, and then they already can't process carbohydrates, and they're taking on these loads in the morning, and then they're having roller coaster rides with their blood sugars all over the place. It's the wrong thing for them. We switch their diets around, and we do a more healthy fat, a higher fat, much lower carbohydrate diet, and there is some wiggle room there. I know there's ancestral diets and paleo diets and perfect health diets and all sorts of diets that we are somewhat familiar with. So we work with the patient and we look at their lifestyle, look at their background to see do they cook for themselves, or is it a mother cooking for kids? I mean, how do we do it so she doesn't have to cook 3 meals for different people in the family? So we're trying to sensitive that to try to make it real for the patient. But if you listen to their concerns and you can work with them, a lot of the patients will make small changes and then become bigger changes. Then they get their numbers back, and in the majority of cases, if they follow through, they're going to see some incredibly improvement in their labs. And you ask them, well, how do you feel? How are you sleeping? How's the exercise now? Are you able to get up and walk a little bit? And you really just try to take it, inch by inch, step by step, and really, as a coach does, you move them on to the next level when they're ready for it.
Yeah, well put. So you don't push them beyond their ability to function, and stress them out to all ends of the earth as part of your treatment protocol. You really work with them and their capacity and ability to move forward with diet and lifestyle change. What so if you could make one change, you said it would be carbohydrate. What's your stance on exercise with these patients? What kind of protocols are you recommending generally, and what are you seeing being most effective?
Well, again, it depends on the age of the patient. I mean, if they're 85 years old, probably the 3 times a week in the gym is not going to be for them. But I mean, many studies have shown the benefit of just walking exercise in some of our senior patients. If they're a younger person, then maybe they can do a combination of resistance exercises, maybe some, I don't like them to just flog themselves with unlimited aerobic. I think there's been recent studies showing that can cause a flabby heart. I think something like just interval training, and again, we have our nutritionist is also certified in personal training. I'm also certified myself, so we go through a physical exercise program depending on their age, their cardiac status, and then if they have a personal trainer, we can talk with them. We understand the lingo, and we can work with their own personal trainer if they have one. If there's somebody who's just never known the inside of a gym, we have other programs. It doesn't take a lot of exercise, but it takes consistent exercise to maintain good biomarkers. I mean, and even walking can, if done consistently, there is a lot of health benefits associated with this. So, in order for them to keep their weight off, if that's a problem for a lot of type 2 diabetes, which of course we know it is since obesity is such rampant this day of age, that consistent exercise, almost daily, if not daily, can make a tremendous difference in having them keep the weight off and keep a healthy body weight, make sure that their insulin works better, keep their inflammatory markers down, improve their mood, improve their bone strength. It has so many benefits. So we work with them to continue this, and we encourage it. But we're realistic. We realize not everybody can go to the gym and pump iron or do some of these marathons. It's just not appropriate. Though I'll have to say that we have a couple of diabetics that have done marathons and things like that because they got their physical condition to such a degree where it was not a contraindication. But that's pretty limited. Most of them, we just try to have them do a reasonable amount of exercise that includes stretching and strengthening and cardiovascular conditioning with aerobic exercise.
What's a typical response in terms of weight loss? So a lot of people come in, will come in and the weight is obviously they're obviously overweight, but maybe weight loss isn't their primary. I guess what I'm trying to say is you take this patient with what we would call diabesity, and they're overweight, their blood sugar markers are elevated, their inflammatory markers are elevated. Let's take an average patient for you who's very compliant and very consistent with your recommendations. What are we talking about, 20 pounds of weight loss, 30 pounds of weight loss? I know that may vary depending on how much they have, but kind of what's typical for you to see?
It varies. It depends. Again, we have to get the insulin down. If the body's sending signals to store fat until we reverse that, nothing we can do is going to reverse that. But typically, let's say a younger patient who doesn't have a cardiovascular history, who's able to exercise, we can sometimes see about 6 to 8 pounds in the first couple of weeks, and maybe a couple pounds a week thereafter, just by cutting down on carbohydrates. What happens is they don't have the insulin spikes, therefore they don't have the hunger, therefore they're not snacking as much. So they're cutting their daily calorie intake down, and they're able to move a little bit more. You're going to get a pound or two a week of safe weight loss, and then we do bioimpedance analysis. So we double check to make sure that it's fat loss and not lean muscle mass, which is the last thing you want to do is to have them go on a starvation diet and lose lean muscle. So we monitor not just the weight, but we partition their different body components to make sure that they're maintaining their lean muscle mass.
Okay, so important note, you mentioned bioelectrical impedance. For those of you listening, BIA, or bioelectrical impedance analysis, is a way to measure body fat composition as opposed to just measuring the BMI, which is oftentimes referred to as the body mass index, which is just a height-weight ratio. The BIA is an electrical measurement that actually measures and can detect how much fat versus muscle a person has. So you measure BIA and you kind of come back at them. You'll see 6 to 8 pounds. That's really, in the first week, that's really quite good. So if we take the average listener who maybe is pre-diabetic, that and I don't encourage anybody to really go out there and do a bunch of fasting or starvation diets on their own, but under decent guidance and good coaching, this stuff is not dangerous to do. It's relatively easy to do, going low carbohydrate. So 6 to 8 pounds in a week, and then 1 to 2 pounds thereafter. Is that?
Yes. I think the first week you get a little benefit because you have some water loss, because when carbohydrates are ingested, then there's some obligatory water that goes along with it. So by cutting down the carbohydrates, you'll get a few more pounds of water loss, which really isn't fat. But after that, 1 to 2 pounds a week I think is reasonable. And the patient, for most patients, if they lose 6 or 8 or 10 pounds, I've had people lose as much as 16 pounds in the first week or two. And the bigger they are, the more they can lose, at least initially, the weight. And then, once they get down, then you have to readjust the calories a little bit because, their basal metabolic rate can go down as well. But it's a slow process, and they will feel better just losing 5 or 10 pounds, and then once they lost 20 or 30 or even more, then it's going to be a life-changing proposition. The only thing I would say is it's really important that you instruct them and that you work with them so they understand that diets really don't work. They have to be on a lifestyle that they can do the rest of their life, and not once you come off a diet, then where do you go from there? And a lot of patients will gain back weight, so we try to change their lifestyle so that for them it's natural, and then they'll lose the weight and maintain it the rest of their life. I think some of the old diets fail just because you had to come off of it, and we try to change their lifestyle, and that's the advantage of having consistent nutritional consultation, so that they don't see it as a diet that they're waiting to come off it. This is how they live their life. So we don't put them on a restricted diet. We say we're going to get you healthy, and you're going to lose the weight while you get healthy.
So health is basically a side effect, or rather weight loss is basically a side effect of good health.
Exactly.
Yeah, excellent point. I know a lot of clinics that are out there that are doing, very powerful hormone treatments for weight loss, and they're charging patients an arm and leg of money to inject them or to put them on, certain types of hormones for this initial weight loss that they experience, but then when they come off of these medications, it really puts them into a tailspin. What are your thoughts on that? I know sometimes hormones can be necessary, but what are your thoughts in general on a lot of these hormone centers that are popping up across the states, where people are being basically given hormone therapy without the rest of the diet and the lifestyle and the exercise promotion?
I mean, it may be a quick fix because some of the ones I'm familiar with, they put a patient on like a 600 or 800 calorie diet, or I think it's like 600. And I mean, you're going to lose lean muscle mass. And once you lose lean muscle mass, when you come off of that diet, your basic metabolic rate is going to be, decreased by so much. It's just a recipe for disaster. If they've come into us, and we have patients who've used a lot of those alternative weight loss, we try to recognize that they wanted to go on this weight loss program because they genuinely want to lose the weight, and that we recognize that. But then we say, you know what? We don't only want you to lose weight; we want you to keep it off. So we do an approach where we I don't want to say validate, but we validate their effort and just say, listen, at this point, we're going to make this other change so that it becomes lifelong, and that you don't have to come off ever your diet because this will be your lifestyle. Because I mean, patients spend hard money to go. So as I was saying, if they restrict calories to only 600 calories a day or so, then it's almost inevitable that they're going to lose some lean muscle mass, and this is going to have a rebound effect once they come off the diet. So what we do is we try to maximize their maintenance of lean muscle mass so that we can keep their metabolic furnace going. And then we don't put them on a diet per se, as we've made these lifestyle changes. We've incorporated these healthy dietary changes, as well as consistent regular exercise, proper sleep, stress reduction, and then we follow up. I see the patient, and then the next time they see the nutritionist, and we really watch their weight. If it varies by more than a few pounds, and we have them come back in, and we go through some other different modalities that we think are more consistent with lifestyle, as opposed to a radical, weight loss or pharmacologic treatment that may have either limited success once they come off of it, or worse, if they've lost muscle mass and now they're just going to balloon back up. I think we've used pharmacologic agents ourselves in the past, but we try to get them off of that. And we found that even after stopping the pharmacological diet aid, they continue to lose the same weight once they incorporated the dietary and lifestyle changes. So it's pretty rewarding when they say, well, you know what, I was having a side effect with dry mouth and agitation with other med, and now I'm not taking it. I'm losing the same amount of weight per week. How is that? And I said, well, because you incorporated lifestyle changes and consistent exercise, you're sleeping better, and you're doing all these things that make for a healthy lifestyle, and you don't have to use the word diet anymore. You've made healthy changes that are consistent.
Yeah, excellent point. I think too often, people have the mindset that looking for the magic pill or the magic button to push for instant results or instant weight loss, but nothing replaces good old-fashioned work and intelligence and common sense with diet change and lifestyle change. Yes,
I mean, we're lucky enough that we can spend enough time with them, with the nutritionist, and really hone that to a high degree, because it's impossible in 10 minutes to go through it all. But once they have an hour visit or something like that, and then we give them handouts and videos and things, we can really see a difference in their education. And a doctor is there also to teach our patients, not simply to treat. And once they teach it, then they are empowered themselves to continue to be at the top of their game when they go out, when they go on vacation, when they have a wedding. We have a lot of patients maintain their weight within 1 or 2 pounds, even though they've gone through vacation or gone overseas or had a wedding of a child or whatever, because they understand the basics. And it's not about being on a diet anymore. It's about making rational changes. And you can permit to so-called cheat on certain days. You just have to know how to do it. And realize that we're all human. Nobody's going to be 100%, but if you do the right thing the majority of the time, you're going to maintain consistently good health.
Yeah, well said, well said. Nobody's perfect. Nobody's a Superman of perfect diet. What if people want to get a hold of you? I know your clinic is in San Francisco, and you guys do some things online as well. Where could I send people? Where could they come and find you and learn more about what you're doing?
Well, they can go to my website at diabesitydoc.com. I'll include that. I'll forward the information to you, and they can take a look at us at that site there. We're just starting to improve our website, so it's a work in progress at this point. But we hope to have more to offer in the upcoming weeks and months. Okay,
excellent. So diabesitydoc.com, and they can learn more about what you're doing in your clinic there in San Francisco.
Yes.
Well, excellent. Well, Dr. T, thank you so much for taking time out of your schedule to be with us today and to share your knowledge and wisdom with the Functional Health Summit. I greatly appreciate you being here.
Thank you, Dr. Osborne. It was a real privilege, and good luck to your listeners. And the last thing I would say to them is try to find a doctor that you relate to. I mean, there's many doctors, whether they have an MD degree or a chiropractic degree, acupuncture, naturopath. There's many doctors that all they want to do is become, an aid and a positive factor in a lot of patients' lives. And the patients should feel comfortable with their doctor and that they're able to talk about a lot of these personal issues and that they feel they're getting a good response. There's many good doctors out there.
Yeah, very well put. Very well put. I think just finding somebody who shares the same philosophy and goals is going to be a better match ultimately for most people who are proactively seeking to restore health.
Exactly.
All right. Well, I'll be in touch with you soon again. I know we've got another event. We're going to be hanging out together soon. But again, thank you so much for taking time out of your day and being with us. And I'll talk to you soon.
Thank you very much.
Have a great day.
Bye.
Bye-bye.